Lupus is the quintessential autoimmune disorder, and there's a lot of pieces you have to know about it, but it, like most of the autoimmune disorders, doesn't really have one confirmatory step. There's not a test you can do that says, yep, you've got lupus. It's going to be more of a clinical syndrome that you have to piece together from multiple clues. So let's start off by talking about lupus, its pathology, presentation, diagnosis, and treatment, and you'll get a little taste of some of the tidbits that come at the end. And then we'll talk specifically about drug-induced lupus and lupus nephritis. So lupus, because we're in the room lecture set, not surprising, is an autoimmune disorder. But also know that it's autoimmune and complex formation. It becomes relevant later. And like most autoimmune disorders, it occurs more often in women, and it just happens to occur more often in blacks than in whites. And remember, it's lupus, so it can present like anything. Lupus and syphilis are the great imitators. Lupus can affect all organ systems, and so you really can't be sure if the thing you're seeing is lupus or something else. So you have to put it together. 4 of the 11, you've got lupus. There's 2 ways that I try to remember this. One's a mnemonic, one's a picture. Pick the one that works best for you. The mnemonic is MD, soap, brain. Now what does that have to do with lupus? Absolutely nothing, but it's the mnemonic that works. First is a malar rash or a discoid rash. And the first 2 go together because they are the rashes. And the malar rash is very unique in the sense that it's this butterfly deformity across the face, but it spares the nasolabial folds. We'll talk about that in just a minute. S is serositis. This causes pleuritic chest pain, oral ulcers. The thing the patient really cares about is A, and that's the arthritis, the joint pain. P is photosensitivity. And this can be subtle. It can be someone who gets a sunburn very easily. If you have an African American who burns very easily, think about lupus. And this is one of the reasons why the malar rash spares the nasolabial fold. If you have your nose touching your skin, sunlight can't get there. So there's no rash here, but there'll be a rash across the rest of the face. It's because of the photosensitivity reaction. B stands for blood. In particular, this means anemia and thrombocytopenia. R is renal failure in the way of lupus nephritis that we'll get to at the end. A is ANA positive. And this is sort of the gateway test because another one of this 11 is immunologic. Immunologic is going to be the other antibodies other than ANA which count twice. That is, the ANA is positive that counts 1, and the other serologic marker counts again. And N stands for neuro. That is the cerebritis. Psychosis, ultra mental status. Now, I don't necessarily like this because I can never remember what it all stands for, so I use this instead, this advanced organizer. Now, lupus occurs in women more often, so she's got long hair. But it's separated by patches of alopecia. She has the malar rash, that butterfly-shaped deformity that spares the nasolabial folds. But she's bucktooth because of all the oral ulcers. And you can see through her skull, and you're looking right at her, so you're going to see the 2 hemispheres on either side of each other connected by the corpus callosum. And these can get inflamed. And that's cerebritis. This presents as psychosis, ultra mental status. Looks like a meningitis, but really, it's just lupus. But lupus can affect more than that. It can affect your heart. And in particular, if you see endocarditis with vegetations on either side of the valve, that's Liebman-Sachs endocarditis, and Liebman-Sachs endocarditis has the same letters as systemic lupus erythematosus, a long name for lupus. The lungs can be affected, but generally not in the way of causing significant pulmonary disease. This is where the serositis kicks in, which is really annoying and painful, but not necessarily dangerous. What is dangerous, though, is the renal involvement. The lupus nephritis is a major cause of morbidity and mortality and can lead to end-stage renal disease and transplant nephritis. And while lupus doesn't really affect the GI tract of the liver. I don't want to exclude it entirely, but really you should not be looking at the bowel as a symptom of lupus. Instead, remember, she's a woman, so she's got a uterus. Look for first and second trimester losses. Early pregnancy losses. They might be indicative of APLA, antiphospholipid antibody syndrome, which can occur with lupus. It causes clots in small vessels, and so baby keeps infarcting and dying. And then there's the things, though, that she really cares about. And that's going to be the arthritis. And for whatever reason, lupus has a predilection for the large joints. Very unlike rheumatoid arthritis, which has a predilection for the hands and the small joints, lupus goes for the big ones: hips, knees, shoulders, elbows. And running through this arm is going to be the blood. That's going to be the low hemoglobin and the low platelets, but also going to be the ANA and other antibodies. So pick which one you want to use. Don't use both. Just recognize that there's a lot of things that can go wrong, and you have to have some method of keeping it straight in your head. Now you'll notice the color coding. The things that are red on the monster are the things that kill her. The things in green are annoying and can be very disruptive to their life, but aren't life-threatening. So when you're thinking, okay, this person's got lupus, you've got 4 of the 11, there are some clues that can help. The first diagnostic step is always going to be the ANA. The ANA is the gateway antibody. If it's positive, something else is probably going to be positive, but it's very sensitive. If the ANA is not positive, chances are they don't have an autoimmune disease. The rheumatoid factor, terribly named, kind of the same thing. The ANA and the RF are negative. Those are both very sensitive tests. They're not specific for anything. ANA does not mean lupus. You start with an ANA when you're thinking lupus. If it's negative, it's probably not autoimmune. But there's still some other antibodies which are more specific. Remember, nothing is confirmatory. There is no biopsy. There is no best test. You just have to put everything together. But if you see double-stranded DNA, this is strongly correlated with lupus nephritis. Anti-Smith is hanging out there, no special correlation. And antihistone. Antihistone antibodies are associated with drug-induced lupus. We'll talk more about both nephritis and drug-induced lupus. But when you diagnose someone, there's some other things you want to do. This isn't necessarily to make the diagnosis, but once it's made, these are the things you need to look for. Because you're going to look for nephritis. You're going to screen her with a urinalysis and urine micro. You're trying to find the nephritis before it becomes really impactful on her life. If you're going to look for inflammatory markers, you can use the ESR or the CRP. And the CRP is preferred if you have to choose between them. And then getting the complement levels. C3 and C4. This is complex mediated. Complements will be low in lupus. This becomes particularly important when you have a lupus flare. They present with fever, altered mental status, chest pain. You don't know if it's pneumonia, which needs antibiotics and not steroids, or a lupus flare, which needs steroids and not antibiotics. If the C3 and C4 are low, it's probably a flare. If they're not low, it's probably an infection. That's where it becomes clinically useful. You probably won't be asked that on the test. And to treat, you have a couple of options. And much like in the rheumatoid arthritis lecture, there's a lot to know about the treatment of lupus. I am going to parse it down to the stuff you have to know. First, everybody gets hydroxychloroquine. We talk about this in the rheumatoid arthritis lecture. Lupus, hydroxychloroquine, rheumatoid arthritis, methotrexate. Lupus, hydroxychloroquine, rheumatoid arthritis, methotrexate. Keep those separate like that. This is going to be for everyone. As long as they can tolerate it, they should be on it. It reduces the number of flares. Steroids should always be avoided in patients. They come at a huge cost: hyperglycemia, hypertension, osteopenia, and then avascular necrosis. So if you can get patients off steroids, do it. But during a flare or during the first diagnosis, you need to give steroids to turn off the flare. The worse the symptoms, the worse she's doing, the more steroids she needs. And then there's going to be the option of IV cyclophosphamide or oral mycophenolate. Mycophenolate mofetil. Both of these can be used for lupus nephritis. You make the diagnosis, it's IV cyclophosphamide. You want to treat them long-term, oral mycophenolate mofetil. And the treatment principles of lupus in general are: when you make the diagnosis, treat them with strong drugs, bomb them, reduce the inflammation, put them into remission, and then scale back. Everybody gets hydroxychloroquine, flares get steroids, lupus nephritis gets cyclophosphamide, and then mycophenolate. There are other things, and if you go onto a room rotation, you might want to learn about them. But if you're just hitting this and for internal medicine or for the M3 level, hydroxychloroquine, everyone, steroids, flare, cyclophosphamide, nephritis. All right, so let's talk about two of the detailed diseases here about lupus. Drug-induced lupus is caused by the antihistone antibody. And the patient is going to present having taken one of the medications that is notorious for this, and there will be a rash, and there will be pain. Serositis, arthritis, and the photosensitivity rash, drug-induced lupus. That is to say, the things that kill you, the cerebritis, the nephritis, don't happen. There's no visceral involvement. The diagnosis is made by recognizing the medication they're on and getting the antihistone antibody. And since it's just rash and pain, no big deal, you remove the offending agent. What medications cause this? The one you should look out for is hydralazine. It's basically the only common one that's still used. The rest of them really aren't prescribed, or they're so common that it's probably not really drug-induced lupus caused by that medication, it's just that they're so prevalent. So hydralazine, drug-induced lupus. Also look for procainamide, which is very rarely used as an antiarrhythmic, since there are such better ones, and methyldopa. Except in the setting of hypertension and pregnancy, and even now it's not preferred, you really aren't going to see these medications. You will see hydralazine. Hydralazine, drug-induced lupus. Remove the hydralazine, the lupus goes away. So drug-induced lupus, no big deal. Annoying for the patient, but not life-threatening. The other one, lupus nephritis, most certainly is life-threatening. This puts people on the transplant list and in dialysis centers. The pathology is going to be mediated by double-stranded DNA antibodies. And the patient is either going to present one of two ways. You are either doing your job and you catch the asymptomatic screen. That is, the urinalysis and the urine micro begin to show proteinuria. If it happens suddenly, or you don't know they have lupus, or you're just not checking, you're going to come in with full-blown hypertension, massive proteinuria, and maybe hematuria. The diagnosis is not made with a double-stranded DNA. antibody. The diagnosis is made with a biopsy. And this is worth knowing. Most of the time, you do not need a biopsy of the kidney to treat what you think it is. In lupus nephritis, you ought to, because the treatment is so toxic. The treatment, as we discussed, is going to begin with IV cyclophosphamide. And then transition to oral mycophenolate. Knowing that this can be the major cause of morbidity and mortality. Right, lots of little details, right? You might be overwhelmed. Let's hit the high points. Lupus, autoimmune disorder, look for the black woman on the test. The things that will kill her, cerebritis, altered mental status, psychosis, and nephritis. Puts her on transplant list. The things that she cares about are going to be the rash, the ulcers, the serositis, and the arthritis. The tests you can get are antibody, the serology. The ANA comes first, double-stranded DNA, nephritis, antihistone, drug-induced. Don't forget about the primary care stuff, urine micro, screening, CRP, C3, C4. In the case of someone with a fever, check a complement level. If they're low, it's lupus. Everybody gets hydroxychloroquine. Flares get steroids. The worse you are, the more you get. Nephritis gets cyclophosphamide and mycophenolate. If you're thinking drug-induced lupus, look for hydralazine. Get the antihistone antibody. And lupus nephritis, get the biopsy. That's lupus.